Excellent. It's 10:04, so let's get a start. Hello and welcome to our Making Digital Health Real series. This is a fortnightly series that aims to provide a space to discuss emerging research, shine career insights, and showcase projects and further network for those who are all interested in digital health. Before we begin, we'd like to acknowledge and pay our respects to our traditional owners on the lands in which we meet today. Today, I'm in the Wurundjeri people of the Kulin Nation, and I'd like to pay our respect to elders past, present, and emerging. We also acknowledge that sovereignty was never ceded and extend this respect to all traditional owners of the lands from which our participants are joining us. With that, I'll pass over to Dr. Kit Huckbale, Validitron Lead, to formally introduce our speaker.
Thanks so much, Shaz, and allow me to extend my welcome to you all. Thanks so much for making time to join us this morning. So as Shaz says, this is part of our Making Digital Health Real seminar series, but this is one of our special mini seminars around which we're calling Collaboratory Conversations, which is about bringing examples from across the world of best practice and leadership around bringing research skills, particularly digital health research skills, into healthcare contexts with the aim of transforming outcomes and changing patient care. Just in terms of logistics today, we have a great speaker. Swami is going to talk to us for maybe 40-45 minutes, and there will be an opportunity to ask questions at the end. But if you do have questions as you go, do feel free to type them into chat. Swami may choose to respond in a moment, otherwise we'll group them up at the end, and everyone hopefully will get a chance to have their questions answered. So without further ado, let me introduce Swami. I had the great pleasure of meeting him for the first time at MedInfo last year, and it's taken us until now to organize this seminar, so I'm very glad that we've managed to finally do it. Swami is an assistant professor. He's also the director of human factors in the Department of Pediatrics at Emory University, which is based in Atlanta, Georgia. And very similar to the mission of the center, and I think the interests of many of us, he is really trying to drive better patient outcomes and improve patient experience with a specific human factors focus that's aiming to improve the way health information technology and clinical workflow are optimized within his local setting. So without further ado, I'd like to pass it over to him for what I think will be a great talk. Welcome, Swami.
Thank you. Thanks, Kit, for that introduction. Thanks, everyone, for having me and providing me the opportunity to share some of our work. So before I start, I want to... okay. I have no disclosures to start, but I do want to acknowledge the people I work with who has helped me tremendously in both sort of thinking through some of the work that we have done, but also adapting and translating these methods. And so for the agenda today, I want to talk a little bit to sort of ground us on our journey with the electronic health record and technology, and then think about challenges incorporating usability testing in operations. Why do we not do that regularly? And then share the approach that we have had within our institution and show some example projects, and then outcomes having adopted that for a couple of years. So to start with, this report came in the late 1990s, where they identified a lot of errors caused within the system, and we know that good people are working in bad systems that need to be made safer. And this is essentially because of the way we have built system that facilitates error instead of trying to prevent them. And then technology was thought as one of the ways we could help address that. And then there came this push for electronic health records, and we know that with the Pass of High-Tech Act in the US, and then the My Health Record electronic sort of health records are sort of used more ubiquitously now. But then the way we have gone about using technology is to actually have some clinical stakeholder give some requirements or some existing paper records, and then an analyst or a builder would build that into a technology as is, and then it goes into the world. Sometimes we do not even evaluate it, or even when we do, we end up with situations where we have either malfunctions or things are obsolete. They don't work and fit to the people's workflow. So the way they imagined when they initially built the system versus how clinicians actually use it in practice is very different. And that leads to a lot of poor outcomes. And so these are just some of the properties of the system design features that we end up with without having to go through rigorous sort of design procedures. And so there has been recommendations on how do we do design, system design specifically, and incorporating evaluation into the development process. And if you look at the system software development life cycle, throughout the phases, the experts have recommended doing some evaluations, including sort of needs analysis, making sure we address the right problem, designing it iteratively, testing it before we actually implement, and then post-implementation also sort of evaluating it and then doing some maintenance and iterative improvements. However, though this is sort of what is recommended, we know that this is not done regularly, and we only do this as one-off efforts or for like funded research projects, but not for all operational IT projects. And so we end up with the same problem that we just saw earlier. So I just want to go through some of the challenges with incorporating some of these testing in operational setting. And before I get into that, I do want to give a brief sort of background on what usability testing is for people who have not heard the term before. It's essentially a method to help with design for frontline users, and we test it with the actual users of the product and see how they use it in practice. So the underlying idea is that seeing how users sort of use the system is better than asking how they would use it or asking them if they like it. Because the way they would actually use the system is very different from them describing whether they like it or not. And in many cases, what people like is different from the actual output of how they would use it or what is good for the system design in terms of effectiveness, safety, etc. And so doing this helps with a lot of things, including identification of errors earlier, knowing if the design matches with users' mental model, and if that would fit their workflow, and if people would adopt it or not. And it also provides us with information about their point of view and develop empathy for them, which is key to designing things. And so if you look at the steps involved in usability testing, you essentially want to determine what you want to test and also why you want to test it. So that gives you a platform for your testing. And then based on that, you want to develop task, scenarios or use cases, and then define success metrics a priori. And once you have defined them, you want to recruit and test users for those cases. And in the end, you would analyze and summarize results, use those to define your design options and iterate on that. But then in practice, if you do want to do it, there are a couple of challenges. One, there is difficulty in recruiting representative users because users are very busy. They don't have time to spend apart from their sort of clinical work. It's hard to find time outside of their clinic times. And it's also hard to find people who might represent the diverse group that they are. Sometimes what you may get, even if you get people outside of their clinical time, is going to be users who either have time or are interested in doing something like this, but you may not get a typical user, let's say. And then the other challenge is that having inadequate resources to conduct these usability studies in an operational context. And there is also time pressures in operations and this want to move on to the next thing or to do something immediately, so that you want to bring up a solution but maybe spend little time on actually thinking about and developing these solutions. And then even if you wanted to do it, sometimes there is difficulty in integrating human factors methods into healthcare operations. And while these are sort of the challenges that we know are sort of preventing us from doing this more regularly, if you do have sort of, let's say, like grant funding or like special focus on a problem, you may try to incorporate these methods. So what we thought after sort of having gone through some of these projects is to actually come up with a modified approach. And I'm going to sort of show some differences between what a regular approach would be and then what a modified approach that we thought could help solve this problem. One, in terms of problem definition, the regular approach is to use some vigorous sort of work system analyses like SEEPs or some analysis approaches where you do a deep dive and understand what the problem is, do some user and task analysis, understand who the users are, enumerate their tasks, understand the cognitive tasks and the other things that they need, how the system interacts, what are the components in the system, and use that to define your problem. While that is good and that's needed, you may not have the time or the resources to do a very deep analysis. So what you might want to do in operations is to have a flexible approach. And in here, for your sort of regular approaches, you might do a combination of observations, interviews, and also come up with work products like journey mapping or swim lanes, whatever that would suit your methodology. You want to be flexible in choosing what you want to do and what you want to get out of those. So a rigorous documentation might be helpful down the line or for publications. In operations, you may get away with having rough notes from fields and just using that instead of having to go through a complete rigorous swim lane diagrams, for example. And also doing these observations or interviews and how much you do them depends on the baseline error rates, the severity of the error, or the number of unique stakeholders you have. And also the experience of the informatics team. If the stakeholder who is part of our informatics team have direct experience on the problem and is a sample representative user, then you want to get maximum advantage of that and try to maybe reduce the number of observations that you may have to do. And also, if you already have a good process documentation that others may have done as part of, let's say, quality or safety work, you want to use that and start that as a reference once instead of having to start anew when you do this problem definition. The next challenge that we have is with recruitment. And usually the way we do recruitments is to approach people by emails or flyers and ask them to participate outside of their clinic time. However, if we do that, then we have a very steep drop in recruitment rates, and it's also hard to get them. It's very time consuming. You have to wait for several days to get somebody to participate. What we have done is what we call as in situ testing. Basically, we go to the actual clinical spaces where this work happens, meaning within the hospital floors or clinic touchdown spaces where people are already working on their clinic job. But then we try to find people who may have 5-10 minutes to help us do this usability testing. And so to help with recruitment, we go with local champions or a familiar stakeholder who is well known with those clinical groups. So we are not strangers, like the people who do the testing are not strangers, and they can do this handshake for us, and they are seen as a familiar face. And by doing this, we improve participant diversity. We get to actually test with people who might not otherwise, participate in such studies. We can also identify prospective participants with them because they tend to actually, once we go to the space, they tend to say, you should talk to this other person. So it snowballs. And then the local champion also knows who we should talk to and good times for recruitment. For example, they may say, you should come right after grand rounds to catch, residents or morning rounds. Or in the ED, you should probably come earlier in the day when the load is lower. So they know good times for the specific use case and the location where we want to go. And that way we get better recruitment or chance for getting people to test with. And then they also provide psychological safety because they are this known phase. And in this, I want to also say that you don't want to have the local champion to be, let's say, the departmental head or somebody who has this power gap with the users. You want somebody who is known to them but doesn't have this power differential with your potential participants. And they have this ability to provide warm handoffs to us. And then the next challenge we have is duration. And this is also one of the reasons why participants may sometimes not be open to participation. And this is because in regular testing, we want to comprehensively test our system. And so we take 60 minutes to, even an hour and a half to test our system. And so that, disincentivizes people to participate because it takes a long time. What we do want to do is to try to actually reduce the time it takes to test. So we try to stick to 10 to 15 minutes rule. Sometimes we also say, if you don't finish by 10 minutes, you want to go, you are free to sort of, walk away. And for some people, we have even tried to have like stop clocks in place so that it helps them to provide that assurance. And to ensure that we do this in only this limited time, we restrict the number of use cases we test them with. Instead of comprehensively testing all use cases, we restrict them to 1 or 2 testing scenarios per participant. And the main thing here to understand is that if we don't do this, then the alternative generally that happens in operations is no testing at all. And some testing is infinitely better than no testing. And you want to select use cases based on the project goals. What are some of the common tasks that people have to do for that project? And then previous safety incidents or errors that have happened, and you want to test specifically on those, or likely errors with the new updated design based on your own heuristic analyses or expert opinion. And also think about edge cases in certain scenarios where it might trip off the participants. And so based on these, you want to prioritize your use cases and then test them with them. And then the other challenge that sometimes happen is with data capture. And this comes to sort of resources needed for doing usability testing. In a laboratory setting, you want to do, comprehensive recording. So you may set up like audio or video recording with the participants, do screen capture, and do a full set of usability testing. If you do want to do that, that's going to take more time. You can't do that in the clinical spaces, and it's just more resource intensive. Instead, what we try to do is to do observations with them, observe as they complete the task, ask them to sort of think aloud as they complete it, and then take field notes. And once we take the field notes at the end of our sessions, we usually member check the field notes with them and then summarize our learnings with them. That way it's verified by the user, so we don't have this problem of bias. And also, because we have tested it right there and we know what the problems are, we know what other things that we want to fix immediately. And again, here, the aim is to optimize feasibility with rigor of your data. And then the next issue that comes up is what environment do we test this in? Do we need a high fidelity environment or a low fidelity prototype? Would that work? And in regular practice, you may use low fidelity, but generally you tend to do testing only when you have a high fidelity prototype or a working prototype. And you want to simulate the whole patient chart and have all the information in there. And that's going to take a ton of time to set it up. Versus what we try to do is to have low fidelity prototypes, even screenshot of an existing EHR interface, and then just change some of the verbiage in there to move things around, or to create PowerPoint mockups or hand sketches, even sometimes to think about layouts or things like that, and share only relevant information or include only relevant information in the EHR environment. And in the use cases, build in other necessary information that you may not necessarily build into the environment, but talk to them while you do the testing. That way they have the information that's needed for testing, you are not burdened with building a fully simulated patient chart. And I already spoke about the kinds of markups that you can use. And the reason we want to do this early testing is because of this advantage with correction and prevention, instead of trying to take back something after you have implemented. And so you want to avoid that cost of trying to go back after implementation, and you want to fix things before you put into production. And then finally, in terms of adjustments and design iterations, what we do generally is to have these testing teams separate from your development teams. And then the testers go and do these testing. They provide feedback to your developers after they do a formal analysis. And then you wait for a meeting with between the testing team and the development team and share your formal analyses. And then they do design adjustments. And then you try to come back and do design changes. And this, as you can imagine, is going to take more time. You have to wait for a long time for doing any design adjustments. You can't test a concept quickly and see if you want to actually go down that path, or it restricts the number of cycles you might want to do. Alternatively, what we do is make the analyst part of the testing team, and we take them to the clinical spaces when we do the testing. And so in between participant sessions, we actually do the adjustments right there, because we have the developer right there for things that we can fix, like some layout changes, wording changes, or like content changes even. We do that even between participants during the same day. And so that way we have very quick iterations. And so overall, if you see, while we do want to keep the key constructs of what usability testing does, we want to adapt it to healthcare operations to make sure it's feasible. And we are trying to, balance feasibility with rigor and what's required to get there. And then in terms of the team members who are required to do this work, one, you need informaticists or human factors engineer who has the expertise, and people who have gained sufficient experience to do usability testing. And so over time, what we have seen in our experience is, the analysts who have come and have sort of seen these testings are now able to do these usability testing by themselves. So sometimes even I don't have to go with them to do the testing. They go by themselves. Two, the locally known stakeholder or champion is very key, because they are the people who know when we should go to a specific location where people might be available. They are the familiar face with the clinical people on site. And so they are able to provide us with that psychological safety, that warm handoff, and they make us see like we are one of them. So that's really important. And then you should also need to have a subject matter expert who is going to help us with designing sort of these test scenarios, specify what the right thing to do with that piece of technology, what we are expecting the users to do. Sometimes, your requesters for some of the projects are these clinical subject matter experts. And so we do need them to be part of the team, and sometimes we can take them to the actual testing cases when they have strong opinions on what the design should be. Usually we try to have them only at later stages, because we don't want them to have that influence on what the users might do because of the Hawthorne effort. And the other thing is, sometimes they also try to sort of talk about what they should be doing instead of letting the task sort of complete or the testing complete. It's hard for them because they know what the right thing to do is, and they want the users to do it, even though it's part of the test. And so you just need to be careful to make sure you don't make that mistake while you do it. And then finally, have your analyst or builder who would join us during these testing sessions and who can set up those patient charts, can adjust the designs as we go through iterations. And I want to make sure it doesn't necessarily have to be like 4 or 5 people for you to work on. One person can fill in multiple roles. For example, a EHR sort of analyst or builder can be a clinician themselves. And so, they might fill in both the subject matter expertise and the builder role. Or it's an informaticist who is a clinician, so they fill in maybe 3 roles because they need to build, they know the clinical area, and they also have experience to do these testing. And apart from the sort of methodological changes for how you conduct testing, there are also some process changes that we do want to adopt. And one of the critical things we want to do is to have leadership buy-in and governance or process changes. And so here I have a process display for what we have done with our clinical decision support, development and testing. So we do user and task analysis in initial stakeholder meetings. We build the candidate design in some test environment. We use Epic, so we just build it within Epic test environments. And then we develop all of the test scenarios in consultation with the clinical stakeholders. Then we put all of those required information into the patient charts, do only what's minimally required. And even when we build some of these test scenarios in the electronic health record environment, we don't necessarily have to build all of the rules for, let's say, an alert to trigger, right? You can just have the representation and assume that the background functionalities for when the alert should fire will be taken care later. That is a technical sort of testing that you would anyway want to do later on, but for the purpose of usability testing, you necessarily don't have to do it. And so that would speed up your process. And then for the locally known stakeholder, here we have Williams, who is our on the site support team lead. And so he knows everybody. And so he hands off us to the clinicians. And so if I go to the space by myself, they'll be like, who are you? Get out of here. Versus if I go with him, they are like, yeah, I have time to do this. And so you really want to have a person like that. And then once you go there, you want to describe the test protocol and provide psychological safety to participants, introduce the scenario, have them walk through the use case, do the observations, and then discuss potential alternative designs from them based on the feedback, modify the design right there, and then iterate till you have no practical learnings. And so with this, approach, we have had many projects. I'm going to share a couple of example projects. One of this is a request that came in for improving our documentation with CVAD, which is your central lines. And so they wanted this improvement because you have these key properties that enable appropriate use and care, maintenance, and removal of these lines. However, those properties are hard to actually identify based on how it was initially designed. And the information, as you know, in the EHR was scattered all across. And so they wanted a redesign of the whole order itself. But then we said, we'll hold on and then think about this problem from a systems perspective. And then we did a user and task analysis. We identified these critical tasks involved with that. One is ordering the actual CVAD. So a physician would make that decision that the patient needs it. Then it's the IR or other sort of qualified provider who would place the actual central line. While they place the central line, it might be the same person who documents it, or it can be a different person who is assisting them who would document it. So the line placer and the documenting person might be different, or it can be at a different time even. And then once you have this documentation, you have use and care of the CVAD. And then there are people who would assess CVAD risk. And then finally, removal of CVAD at the end when you feel like you don't need the CVAD. Right. And then the people who want to do assessment of the risk and placing the central lines are usually intervention radiologists. But then the people who have to do day-to-day care and maintenance are your bedside nurses. But then when you think about what goes into documentation, the information for that comes from the actual line placement, not necessarily order, because sometimes what's ordered and what get placed are different. And so it's usually the people who place the order has the most of the information for what to document. And also based on ongoing risk assessment, they would document some of these things about CVAD. But then that documentation drives your use and care for the central venous access line. It also drives when you want to remove the line. And so based on this understanding, we created several sort of scenarios. And then the properties that we want to know that drive some of those, care processes are whether the line is tunneled or not, whether it's cuffed or not, whether it's a high flow line or a low flow line, or whether the material used is silicone or not. So based on these, we created several scenarios in test patients and then had realistic charts where you had this information somewhere buried within, like how it was in practice, and then tested, are they able to identify the properties and are they able to do the right thing? So based on our testing, we made a bunch of changes. And so this is sort of the redesign that we did. So initially, if you see here, the line said, power port and then jugular for right. Then we changed that to having those specific properties and surface them to the users directly as part of the line names. So they would know, instead of having to go deep into the chart, they might know right there whether the line is high flow or low flow, whether it's tunneled, cuffed, etc. And then the other thing that we did is while we surface it, we also enable people to document it at the time of line placement. Previously, this was all in like notes in free text, and sometimes people do document it or they don't. And so we made it structured, but we also allowed for this unknown option so that even at the time of placement or when they create this documentation, sometimes they may not know this. We allow a way out for people. That way they can continue with caring for the patient. And then we also created a dashboard that would help people to know lines that have missing properties, and then across campuses. So we have shown here 2 campuses, Eggleston and Scottish Rite, and you can see those that have missing properties. And so then the intervention radiology team can go in and fix that documentation later. And so after we did this, we found that the ease of use score on 100, changed from 15 to 80. And then the frontline users' perception of key properties, whether they were able to identify key properties, also improved significantly. And finally, in terms of the expert agreement on key properties, previously, less than 50% of the times they agreed on what the line was, which was very shocking. And so after our redesign, it improved significantly. And then this is sort of a second example that I wanted to share, just to show something that's outside of the electronic health record. This was with how did we improve our dashboard for analytics. And the things that people wanted to do with this one was to understand the performance over time, and also know what the outliers were across, and so that they know where to focus on. People were also interested in comparisons to peer groups, and also have all of this in one glance so that they don't have to go back and forth and have this navigation problem. But then if you look at how this is designed, they can't see all of the metrics at once. right? You have some interface problems where you have these yellow colors that doesn't have any sort of real meaning. It's just used for like the header. And then the definitions for what those metrics are on a different page. So even if they look at it, sometimes people didn't know what exactly they were looking at. And you have these dual axes without actual axis labels. And so it's again hard to interpret what they meant. And then again, some more usability problems with frequent filters being hard to find, and it's very hard to do outlier detection with this because you have to go look at one at a time individually and then have to remember and come back to each group. So we again did all of the user and task analyses and identified what people want to do. And based on testing, we landed with this new design which aligned with people's critical tasks. And so with this, now you can see that everything that they want to look at, all of those measures are in one place. They don't have to scroll to find that. They can look at the trends and also have these comparisons with peers and identify outliers. And then the colors are sort of used minimally, while we do have the red, green, and yellow, which I do want to avoid sometimes. Sometimes the leadership just wants to use it. So if you do want to use red, green, and yellow, try to use non-saturated colors. And then also have definitions for what those metrics are right there so that they don't have to go to a different place looking for that information. So those are just two examples to say how we sort of improved our design, adopting these techniques. And then finally, looking at outcomes at Showa, adopting this across use cases. If you look at 2019, when I sort of joined our team, a year before, my CMI, now CMIO, he was a assist before he started doing this for ad hoc projects. And when I joined also, we did usability testing ad hoc for specific projects, right? But then what we realized is that we are not doing this for every, CDS implementation. And then we went into why did we not do this? And we came across these problems and we try to adapt. And after we made those governance changes and those modifications to our methodology, we ensured that this was required for all CDS except for like critical cases where it's an emergency. And if you see here, the application of these and the number of users we tested this with has increased tremendously over time. And it's not just that. We have now, in the last year, 2 years, we have completed over 35 projects. We have used some of the preliminary data for some of these for grants, and have also applied some of these for our newer grant proposals. And we have 6 grant awards, and we have over 20 manuscripts with these methodologies and over 50 conference abstracts. And this is specifically because we were able to scale this with our clinical operational staff. And we have, now operational staffs and informaticists who have, published and also presented at conferences because they have adopted this methodology and they have data now. And doing this because they have sort of followed us during our usability testing, we have so far trained 5, staff members on usability testing, and they do it now by themselves. And then we have recently, just a couple of months before, started a program to train staff on human-centered design and how we adopt this methodology so that we scale this across not just our CDS team, but also other applications within our IT department. And so just to recap, what's needed to make this a routine practice. 1, you need buy-in from the leadership. We want to slow down to speed up, as the IDEO president says, and you want to incorporate this into a standard practice. Two, you want an interdisciplinary team that has the expertise required to do the testing, have the stakeholder who can, do that warm handoff and help you with the recruitment, a subject matter expert who will help you with designing those test scenarios and identifying the critical problems that you need to test with, and have a builder and analyst who could join you as part of the testing. And then have these modified testing procedures so that you do the recruitment directly at site, and then also relax some of your data collection instead of trying to be very rigorous. Try to have 80% of rigor so that you make it feasible. And then also have some truncated experimental designs. So instead of having to do like a randomized block design, you might want to do smaller test cycles, fewer use cases, and do rapid iteration where you can actually make those changes right between test sessions, and you don't have to wait, even a week or a few days to make those changes. And then finally, I know people are sort of maybe experts and they already know how to do usability testing, but I just wanted to give some pointers on things to remember and do while we do usability testing. Is one, to always do a pilot run so that you ensure that the system is working, that the scenarios that you have are sound. Two, provide psychological safety to your participants. So, I usually say to them that we are not testing you, we are testing our system, our build. And so if anything, we can fail, you cannot fail. And so that helps them to, feel a little bit safer. And then we also do not specifically say what we are testing about. And we have to remember that this is not an exercise to justify what our design is, but to remember that this is an exercise to get feedback and understand users' perspective. And then before you do the testing, you do want to make sure that your system is working, have a checklist for all of the things that you want to test, and make sure you have already defined what your tasks are going to be, what your success criteria is, and what you are going to specifically observe with and get feedback on. That way you don't change what your sort of success criteria is, both, post testing. Hope that was clear and not the way it sounds here. Thank you for the opportunity. I'm happy to take questions.
Thanks so much, Swami, for a great talk. Really appreciate it. So yeah, I'd love to throw it open. Does anyone have any questions? Feel free to raise your hand. I think RL, one of the participants, you typed some notes as questions, but I don't know whether you want to, if you're brave to go on microphone, or whether you want to retype your question, because I'm not exactly sure what you're asking.
Sorry, thanks. Yeah, just apologies for RL. Too many Zooms. I just truncate. My name's Richard Luntz. Good day. Thanks very much. That was brilliant. Morning, everyone. Yeah, just interested in the process. Are your stakeholders, including the admin staff or the patients themselves, just in terms of how they see the process, or is it just an internal process from users? And then how do you budget for this, and what's the time constraints on that?
Yeah, in terms of the stakeholders, we have minimal, I would say, patient involvement on this one. So it's mostly internal staff, IS&T staff, clinicians, and other stakeholders, operational stakeholders mainly. And so in terms of the budgeting and cost for this, the cost is essentially increased time to do some of these work. So the completion of the project delivery times are going to move a little bit more because you are going to slow things down. There is going to be initial pushback and hesitancy in trying to adopt some of this. People would be nervous also, but what I have seen in practice is it just takes them a couple of those testing sessions to actually get the impact. They have this aha moment. I remember the first time we had our one of our testers. They came in, and then initially they thought what they had built is going to work, right? That's what we think, like what we build is going to work. And then the first thing the participant did was like, I will delete all of this. I don't need it. And that's the thing that they spent the whole time trying to build. Right. And so then they went into why and all that, right? But then they immediately understood that it is so much effective to understand this a priori, because what would have happened in practice is we would have made the change, and then after implementation, we would have heard murmurs or like actual complaints, and then we have to go back and fix it. So if you look at the overall project time versus what you have with here, it's reduced actually, right? So this is I would say a long-term gain for us. In the short term, you are going to lose some time because you are slow on delivering and completing your project, but long term, you definitely benefit. And so in terms of the cost even, right, the analyst time or the stakeholder involvement time, it does increase initially, but then if you look at overall, it's actually a save, a win for them.
Is that great? Okay, thank you.
Yeah.
Does anyone else have any questions? Please do feel free to raise your hand or type into the chat. So Swami, I have one while maybe people are thinking, which is about, I think it comes across so clearly from what you've shared about the value you're creating for the health services side of this equation, but you yourself are an academic coming from a university context. How does the value story work in the other direction? Is this helping you drive a research agenda? How do you tell the story of value back to your, I guess, your research supervisors and departments?
Yeah, so that's this thing, right? So when I initially started doing this, like this is my like benefit of doing this. I am sure if I did like the rigorous, methodology or the regular way, I might have had a couple of more maybe impactful like projects. I have had challenges, I should say, getting some of my work accepted for publication because it's not as rigorous as the traditional way of sort of doing some of these things. But then, on sometimes reviews are what they are, but then I have more publications with this than I would have had otherwise. I can use a lot of this data as preliminary data for my grants. And so because I have collected this grant, which I might not have had an opportunity to do otherwise, and because I have this preliminary data, we have used this on applications and they have even got funded because we have done that, right? The MedInfo, presentation that I did last year was through one of these for doing like dosing based on patient's weight. Right. So all of these actually help with academic productivity because you do get to publish on them and present them.
Thank you. So Nilva has a question. So they were interested in knowing if you've identified any high-risk workflows and applied usability testing specifically in a high-risk context, and if so, what were those workflows, or if you have any examples, and was this all based around Epic?
Yeah. So in terms of workflow, one of the projects that come to my mind is with our blood product ordering and administration process. That was definitely a high risk one. We have now gone through maybe 2 or 3 cycles, I should say, with that one. The challenge is, not everything needs a technology solution or has a technology solution, right? And so you do need to understand the other sort of components within your health system, within your work system, and how that contributes to your outcomes. And so while doing that project, we were able to actually surface a lot of problems because it did involve stakeholders across groups from, your ordering providers to blood bank, nursing, phlebotomy, who collect, samples. A lot of people were involved in that, a lot of processes and decision-making points. And so there were a lot of gaps in the process. And so we were able to actually make process changes everywhere because we had done that analysis. I should say for that one, we actually had a very heavy system investment on that one, and they did a whole value stream analysis. They had a consultant from outside. But I also felt, even though they spent all of that investment and they had identified a lot of issues, I would say prior to doing that investment, I had sort of started collecting some of this information by myself. And I identified, I would say maybe 80% of these problems, right, by myself. It did take like much less resources to do it. I would give that I didn't like, identify some of the things that they did because again, it was a whole, it involved a lot more people. It had a lot more resources to do it. But then I feel for like even complex workflows, you can adopt these methodologies and move quicker on things if you have problems, especially trying to move on projects.
Great, thank you. Kath, you've got your hand up.
Yeah, thanks very much. I had a query. Recently, I've been at a presentation and they spoke about not doing pilots. So just do it. Don't do a small version. Don't call it a pilot. Just make the change. And then obviously, if you're doing some sort of evaluation, you can then make some decisions around the optimization. And I sometimes do one and sometimes do the other. Just your thoughts on that. And the other point is, I think if I work in allied health, so I have a lot of professions. So sometimes I will make a change in one profession, but I sort of lose momentum to get through the 12 professions. And just any ideas on that as well?
Yeah, so to answer your first question on, just do it, I think it's actually sort of a trade-off on things, right? So for some of the things, if we start doing it in one location, right, because it's sort of integrated health system or just people just get to know things about, either they are like, why don't we have it? Or, it becomes a disaster and then they are scared or they don't want to do it the next time. Like there is this cost to change. And every time you put in something new, you have to justify why you are making that change to stakeholders. And so I think it's sometimes better to make sure a little bit on, where you are getting at. But then even that just do, right, even for some of the implementations that we have done, we do actually pilot it in like one location and then expand it and then expand it and then expand it. And then just doing it doesn't necessarily mean we don't test it at all. We can even test it with like, sample of few user groups, right? And your just do it can be your usability testing, because you are now testing it with potential users. The only thing is you have not gone live. The advantage of actual implementation is you might identify or uncover workflow challenges, which are hard to find with usability testing because you never know how people would use it in practice. And so those small pilots actually help you uncover some of those challenges, which you will not get in. While they may speak of some of those workflow challenges in your testing sessions, you may not uncover a lot of those in them. And so I do agree that, for whatever you do, sometimes it's just, you don't have to do big bang implementations and do it across all. And you can sort of go step by step. But it also depends on what the use case is and whether you want to have uniformity across your system versus you want to justify and move or bring people towards accepting that change. And so if you want to do that, then small pilots are easy because now you have shown improvement in one area, people are more likely to adopt it in other areas. I don't know if I answered that.
Yeah, that was great. Thank you.
And then what is the second question? Sorry.
The other one was just about if you are piloting and you have a lot of areas to go to, just running out of steam by the time you get to the final areas.
Yeah, that's true, right? So if you do want to do it, right, what I tend to do is to actually prioritize testing with user groups that have either high usage rates or high error rates, like things that actually drive your outcomes. Doesn't necessarily mean that we ignore the other groups, but if you have the time and resources to do it for everybody, then great, do it. But then for a lot of operational stuff, I just try to prioritize what we want to get at. Usually, I if there are many groups, what I try to do is I don't test a lot of participants from one group. I try to like reduce the numbers from each group so that I reach out to multiple groups. While I do only, let's say I do only 20 overall, but then I have, let's say, 6-7 participant groups or professions, then I try to do only 2 or 3 per group, right? It's a small sample size, I agree, but it's better because you would uncover more from each. So like you have more value for your testing than trying to do more within one group. And I don't know if you have seen this from Nielsen, and I like this one, where he sort of talks about how many users you need. And this is, I should say, this he says for only one type of user group or profession, right? And so if you have multiple groups, what you want to do is test all of them with at least 2 to 3 participants per group.
Thank you. And Melinda, you've just got your hand up. Just time for one last question.
Yes, thank you for the opportunity. I actually have a question that's probably like aligned to what Keith has asked. So I think this research is a little bit different from like maybe because I come from more of a biomedical perspective. Usually we have like more of like a quantitative data where you have like numbers and repetitions. So I guess like the research methodology can like is more like robust. And so in your case, I think the study is more like qualitative and more like gaining insight from the users, especially during the immersion process, like observing in the hospital and then asking questions with the key opinion leader or the stakeholders. So I just wanted to know if there's like, I don't know, maybe like a specific method for I don't know, reducing bias. And let's say what happened if maybe you have like a different or opposing input from one person with others, like the one you interview or you discuss. I mean, like the input you receive from a stakeholder. I think that's like an area that I'm quite interested to hear on. Thank you.
Yeah, that's usually one of the challenges is, do we address this concern for the participant, right? And that's a forever question, I would say. But with experience, you do actually get a sense for, is this something that is going to be a problem for everyone, or is this something that's a 1% problem? And so the way we deal with that is, if it's a problem, we will try to go to a couple of next set of users and see if that repeats, right? If it repeats in the next 2 participants, then we definitely know that's a problem. If it doesn't, then we apply our experience basically to say and think about whether we should apply any changes to that. And then to your question on quantitative data, using this method, you can still get quantitative data, right? So your usual metrics on how many errors people make or whether they completed the task or not, how much time did they take, you can do all of that while you do this testing. It's just that you are not in a lab. You have, let's say, 2 people who go, and so one of the other person can do all of those observations and note down the times. What you are not going to have is a randomized block control or repeated measurements. But what we have done is, for some of those use cases like the blood orders one, having recognized that this is a serious thing, and also to show that it also depends on what your purpose is, right? If your purpose is to collect that data and show that your design is better than the previous design or that it's an improvement, then you do want to have this design and actually test use cases in some randomized fashion. And so we made a blog design, but had the testing in situ. And so that way the recruitment was easier. We completed like 20 testing in 2 or 3 afternoon sessions, right? I don't think we can do that with our traditional approach, but we did, I think, complete all 20 user testing in 3 afternoon sessions. And we have sort of published on that one also. It's just accepted an ACI for our blood product order improvement with this methodology. So you can have quantitative data, but then deciding on how many you want to test with and how rigorous you want to get and what you want to capture depends on what your outcome is. If it is something where you think that data is going to be helpful for either research or for convincing your stakeholders or for showing improvements from previous design or for your own understanding, then you want to go ahead and do that. But if it's like something where you want to make quick decisions and move on, you may not want to do like testing with 20 people. You may be satisfied with like, 6, 7 users, and that's it.
Great. Thank you so much, Swami. So we're just over time. So I would like to just take this opportunity once again to thank you so much for your talk today and your generosity in answering all the questions we have. Thank you everyone else for making time for this seminar, and we look forward to seeing you at the next ones. Otherwise have a great Wednesday. Thanks so much.
Yeah. Thanks everyone. Thanks for the opportunity.